Welcome to my channel, Surgery Nuggets by Dr. Himashri. Today's topic of discussion is gallstone, the most common and most important of all the surgical conditions that we get. So today is part 1. Now let's start with the introduction of gallstone. Gallstone are the most common biliary pathology. They are asymptomatic in more than 80% of the cases, and almost 1 to 2% cases per year will develop symptoms requiring surgery. Before going to the pathophysiology of gallstone, let's discuss the anatomy of gallbladder first. So, gallbladder is a pear-shaped organ. It contains around 25 to 30 ml of bile. So, gallbladder develops from cystic diverticulum. At around 4th week of gestation, a hepatic diverticulum develops first, from which the cystic diverticulum arises, ultimately leading to gallbladder and the biliary tract. So anatomically, gallbladder is located under segment 4 and segment 5 of liver. To know the anatomical plane between the liver and the gallbladder, we have to know what is cystic plate. So what is cystic plate? It is a fibroareolar tissue. It is a condensed fibroareolar tissue plane between the liver and gallbladder. So what is the surgical importance of the cystic plate? During dissection of the gallbladder in open cholecystectomy or laparoscopic cholecystectomy, if we stay in this cystic plate, then bleeding will be minimal, and also any chances of injury to the important structure, blood vessel or duct of Lashka, is least in this plane. So that is cystic plate. Now, what are the different parts of the gallbladder? They are divided into fundus, then body, infundibulum, and neck. Now, coming to Hartmann pouch, what is Hartmann's pouch? It is a pathological condition. What happens when the gallstone is impacted? Suppose this is the GB. So when this gallstone is impacted here at the neck, it will produce a outpouching. And this pathology in the infundibular region created by the gallstone. Now, what about blood supply? The main blood supply to gallbladder is from cystic artery. Which is a branch of the right hepatic artery. I'll show in the next slide the anatomy of cystic artery, the course. Then sometimes we have seen that occasionally accessory cystic artery is also found, which arises from the gastroduodenal artery. So this is accessory cystic artery. Another important term associated with gallbladder and the biliary tract is Calot's triangle. Very important, Calot's triangle. The original Calot's triangle is modified in recent years. So the Calot's triangle or the hepatocystic triangle boundaries are laterally we have the cystic duct and the medial border of the gallbladder. Superiorly we have the inferior surface of liver, and medially we have common hepatic duct. Let's see the picture. So the first one is a diagram to show different parts of the gallbladder and the cystic duct. So here you can see, this is the first picture. So here you can see this is the gallbladder fundus. This is the body of the gallbladder. Then we have infundibular area, neck, and then cystic duct. Now the cystic duct combines with the common hepatic duct. How it is formed? The right hepatic duct, left hepatic duct, they form the common hepatic duct. Now cystic duct and the common hepatic duct joins here to form the common bile duct, CBD. So this is CBD. The cystic duct is around 3 cm in length. Diameter is around 1 to 3 millimeter. Now second diagram here, the same diagram, but you can see some spiral mucosal fold inside the cystic duct. These mucosal fold are called valves of Hester. Valve of Hester. And then there are some sphincter in the cystic duct that is called sphincter of Lutkens. These two are the important anatomical structure. Now again, this is cystic duct, common hepatic duct forms CBD. This is the duodenum. This is the duodenum, and this common bile duct joins with the pancreatic duct. Can you see? This is pancreatic duct. They will join together at the ampulla of Vetter. This ampulla of Vetter is guarded by sphincter of Oddi. So this is sphincter of Oddi. Next, we have the histological image of the gallbladder, wall of the gallbladder. So the mucosa of gallbladder contains simple columnar epithelium. It contains simple columnar epithelium, but the characteristic feature of GB wall is that it doesn't have a submucosal layer. Submucosa is absent. It doesn't have a submucosal layer. Then the muscularis mucosa is also absent. So gallbladder doesn't have a submucosal layer. In the mucosa, you can see some fold. These are the mucosal fold, also known as the crypt of Lashka. These are the diverticula or crypt known as crypt of Lashka. Next slide, we can see the blood supply to the gallbladder. So blood supply to the gallbladder comes from this is abdominal aorta. Okay, let's see. So this is abdominal aorta, and this one is celiac trunk. This is celiac trunk. From the celiac trunk, we have one big branch, that is common hepatic artery. Now, from the common hepatic artery, the branch going above is the hepatic artery proper. This one. This is hepatic artery proper. From hepatic artery proper, you can see the descending hepatic artery. This is right hepatic artery. From right hepatic artery, the branch that is coming down is the cystic artery supplying the gallbladder. So this is the cystic artery. Again, hepatic duct forms the common hepatic duct. Then with cystic duct they join to form the common bile duct. This common bile duct is coming down, joins the pancreatic duct. This is pancreatic. This white color is the pancreatic duct. They join the ampulla of Vetter. Here I have shown the Callot's triangle. This is a diagram to show the boundaries of Callot's triangle. Let's say these white dotted lines represent the Callot's triangle. So as you can see medially, what is it? This is common hepatic duct. This green color structure is the right hepatic duct. This is left hepatic duct, Y-shaped, and the stem of the Y is the common hepatic duct. This is common hepatic duct, and it forms the medial border of the Callot's triangle. Then laterally if you see the medialmost part of the gallbladder, you can see it forms the lateral border of the Callot's triangle and also cystic duct. So laterally we have two structures, medialmost part of the gallbladder plus cystic duct. Cystic duct. And the superior border of the Callot's triangle is formed by inferior surface of liver. So this is the boundary of Callot's triangle, also known as the hepatocystic triangle. What is the content of Kellogg's triangle? What is the content? In old literature, this is cystic artery. This is the cystic artery supplying the gallbladder. In old literature, cystic artery was considered as a boundary of Kellogg's triangle. But nowadays it is considered as a, according to the latest guidelines, it is a content of Kellogg's triangle. So what are the contents of Kellogg's triangle? One is cystic artery, one is lymph node of Lund. These two are the contents of Kellogg's triangle. Now coming to the different types of gallstone. There are mainly three types of gallstone. First is most common cholesterol stones. First is cholesterol stones. Second is pigment stone. Pigment stone can be black or brown. Black or brown. And third is mixed stone. Let's say this is a diagram. You can clearly see the difference between different types of stones. So first one is cholesterol stone. First one is cholesterol stones. In USA, this is the most common variety of gallstone. Cholesterol stones are usually solitary. Cholesterol stones are usually solitary. Usually they are single. On the other hand, mixed stones. Mixed stones are most common in our country. The third picture you can see, it contains cholesterol. So mixed stones, they contain cholesterol and calcium salt of phosphate, carbonate, palmitate. Then it also contains the proteins. These mixed stones are multifaceted. Can you see? They stones are in a compact space, so they are multifaceted. Impressions you can see here, they are multifaceted. Pigment stones. Pigment stones can be black or brown. So the black pigment stones, they are common in gallbladder. It is usually calcium bilirubinate, calcium phosphate and bicarbonate stone. On the other hand, brown pigment stones are usually formed in the biliary tree, and they are the most common cause of brown pigment stone formation is infections like E. coli or bacteroids. Let's see in the next slide. See, the first one is cholesterol stone. Here I have compared the different types of stone and their characteristic. The first one is cholesterol stone. Position can vary 50 to 100%. These kind of stones are more common in the USA population. Okay, so common location is gallbladder, but it can also occur in the bile duct. Diagnosis by ultrasound. And what are the clinical association? They are metabolic, family history can be positive, fertile female of age group above 40 years are more common, who are obese, they are more prone to develop cholesterol stones. Now coming to second category, that is the black pigment stone. Black pigment stone, they are calcium bilirubinate polymer stone found in the gallbladder, and clinically they are associated with increased or altered bilirubin expression in hemolysis. All those hemolytic diseases, you know, sickle cell anemia, pigment stone in the gallbladder, then cirrhosis, cystic fibrosis, Crohn's disease, or advancing age. These are common factors for black pigment stone. Third one is brown pigment stone. As I have already mentioned, these are mostly seen in case of infection by E. coli or bacteroids. Okay, E. coli is most common. E. coli or inflammation or infestation because of stasis or stricture can lead to brown pigment stone formation. Brown pigment stones are mostly seen in bile duct. They are unconjugated bilirubin and calcium source of fatty acid, cholesterol, and also mucin. Cholangiography is done to detect cholangiography. Thick biliary sludge is a thick sludge-like pigment of calcium bilirubinate, cholesterol monocrystal, and mucin, which is actually a precursor of gallstone, seen in gallbladder. And clinical association are seen in case of long fasting, or if a patient is on total parental nutrition. This is also one precipitating factors. Then pregnancy also another risk factor for developing biliary sludge. Coming to pathogenesis of gallstone formation. Four main criteria are responsible for gallstone formation. Number one is impaired gallbladder function. Impaired gallbladder function means if there is any problem in emptying of the bile into the cystic duct, or any absorption deficiency, absorption defect or excretion defect, it can impair the GB function. Second precipitating factor is supersaturated bile. Cholesterol, main component of bile is cholesterol. Cholesterol, which is secreted in the liver, it is basically insoluble. How it is made soluble? Salt plus lecithin. So the relative concentration of cholesterol is to bile salt and lecithin is what makes cholesterol soluble. Bile salt plus lecithin is to cholesterol is 25:1. This is the normal ratio. If bile salt plus lecithin is to cholesterol ratio decreases to 13:1, that means cholesterol has increased and bile salt has decreased overall, then the ratio becomes less than 13:1. It means now the bile is saturated. Now is bile is saturated with cholesterol. Now the bile is saturated with cholesterol. Then what happens? Now what happens? The cholesterol crystals will form unstable micelle normally, but as the concentration of bile salt has reduced, the micelle that is formed, they are unstable. They are unstable, leading to precipitation of the crystals of cholesterol, and ultimately it will form a monohydrate crystal and gradually gallstone formation. Induce it, for example, heat labile, glycoprotein, some infestation, GB, motility disorder, all those lead to gallstone formation. Okay. Third factor of gallstone formation is cholesterol nucleating factor. I have already mentioned some glycoproteins, mucus, infections. These are also leading factors for nucleation, and forming monohydrate crystal, and then finally the gallstone. Absorption or enterohepatic circulation is the fourth major factor. If there is any disturbance in the enterohepatic circulation, then also gallstone formation increases. For example, deoxycholate, bowel transit time, also another important factor. Fecal enteric flora, eyelid resection, cholestyramine are important factors for maintaining enterohepatic circulation. So that the three important factors of crystal formation is supersaturation, hypomotility of the gallbladder, and then nucleation factors like glycoprotein, mucus, infection, etc. All these will combine to combine and lead to crystal formation, gallstone formation. So on the right side diagram, the first diagram you can see, this is the micelle. What is micelle? Micelle is bile salt plus lecithin. Micelle is bile salt plus lecithin with cholesterol. So when the cholesterol amount increases, the micelle may be unstable. There are other factors also like GB. All will lead to formation of crystallization of the cholesterol because of supersaturated bile. Bile is now supersaturated with cholesterol, and they will start to precipitate these crystals. Precipitation and stone formation occurs by infestation, and any condition which increases the cholesterol secretion in the bile or they reduce the bile salt concentration causes stone formation. Hunt's aphorism says, it states that a gallstone is a tombstone erected to the memory of the organism within it. That infection is a precipitating factor for gallstone formation, important factor for gallstone formation, and also gallstone is a source of infection to cholangitis, a life-threatening condition, cholangitis. So gallstone, the effect of gallstone. So most of the gallstone are asymptomatic. It is an incidental finding in the ultrasound, sometimes associated with biliary colic. So what is biliary colic? Biliary colic is a sudden spasmodic pain which may remain for few minutes to 3 to 6 hours and then subsides. Usually this kind of pain wakes the patient up at night, increases more after fatty meal. So biliary colic, after a few days or months, it may reappear. Then acute cholecystitis. Acute cholecystitis is a constant kind of pain which stays maybe more than for 12 hours, associated with fever, nausea. Cholecystitis, empyema GB, mucosal of the GB. Mucosal of the GB, the bile is sterile, but empyema of the GB means mucosal can progress to empyema of the gallbladder where bile is infected. Okay, then ultimately perforation of the gallbladder, it can lead to perforation peritonitis. In the CBD, what the gallstone can do in the CBD? It can cause obstruction of the bile duct, leading to obstructive jaundice, then ascending cholangitis because of the infection, pancreatitis, and sometimes Mirizi syndrome. In the intestine, the gallstone which is larger than 2.5 centimeter, usually it is seen that sometimes they may perforate and form a fistula that is called cholecystoduodenal fistula, and the symptoms usually are similar to intestinal obstruction. That is why also known as the gallstone ileus. Now see this diagram, it shows the different position of stones. The first one, the stones you can see in the hepatic duct, left hepatic duct. These kind of stones are called hepatolithiasis, intrahepatic bile duct stone. Hepatolithiasis contains mainly brown pigment stone and cholesterol stone. Second, this is the gallbladder. So here, these are the stones. These are the gallstone. Cholelithiasis, gallbladder stone, cholelithiasis contains cholesterol or black pigment stone. Then comes the third part. Third one is this green structure is the CBD, common bile duct, and these are the stones. The third one is extrahepatic bile duct stone called choledocholithiasis. Primary stones, the primary stones of the CBD are brown pigment stone. The primary stones in the CBD, they are brown pigment stones. Whereas secondary CBD stone, that means they did not originate in the CBD, but they have come from the gallbladder to the CBD. So secondary CBD stones are usually cholesterol stones and primary are brown stone. Let's discuss the clinical features. Gallstones are increasingly detected incidentally. As I have mentioned, they are mostly asymptomatic, no pain. Sometimes patient will complain of flatulent dyspepsia. Flatulent dyspepsia is not a typical pain, but it is a feeling of fullness. So flatulent dyspepsia is a feeling of fullness or belching immediately after taking a fatty meal. That is called flatulent dyspepsia. mostly seen in the right upper quadrant or epigastric area. Then right upper quadrant pain radiating to the right shoulder or tip of the right scapula. Biliary colic, as I have mentioned, fever, vomiting. Now here I have differentiated biliary colic and acute cholecystitis. So what is biliary colic? Biliary colic is sudden spasmodic pain due to intermittent obstruction. Intermittent obstruction of cystic duct or CBD by stone, and it subside within 3 to 6 hours. There is no GB inflammation. There is no GB inflammation. So once the stone, suppose the stone was impacted at the neck, once the stone moves towards the gallbladder or towards the CBD, this obstruction decreases, then pain suddenly disappears. So this is biliary colic. Then acute cholecystitis, on the other hand, it is a constant pain, sharp but constant pain, and it lasts longer than 6 to 12 hours. There is definite inflammation of the GB, which is manifested as fever and nausea. That is acute cholecystitis. And what is cholangitis? Cholangitis is a life-threatening condition which is caused by ascending bacterial infection of biliary tree due to obstruction by the gallstone. Now here, the first diagram is the Moynihan's method. This is Moynihan's method of looking for GB tenderness, and second is Murphy's sign. So how Murphy's sign is done in sitting position and during deep inspiration. It is done in sitting position. During deep inspiration, if we palpate the right upper quadrant, just below the right hypochondrium, if we palpate, then the patient winces with pain at the summit of the inspiration. At the summit of the inspiration, patient winces with pain, and there is a halt in the inspiration. That is called Murphy's sign positive, seen in case of acute cholecystitis. So Murphy's sign is positive in case of acute cholecystitis. Acute cholecystitis, it is positive. Moynihan's method is also same, but it is done in lying down position. So Moynihan's is done in lying down position. You can see here the examiner is using a thumb to press the right hypochondrium. Deep inspiration, the inflamed gallbladder touches the finger of the examiner, and patient winces with pain and halt the respiration. That is Moynihan's method. Very important. Coming to investigations, these are some of the most common investigation I have mentioned. I have not mentioned all the investigation that can be done in gallbladder disease, whole abdomen. So what are the things we see on ultrasound? First we see, is there any presence of gallstone? Presence of gallstone, and also any stone in the CBD. That means we see the biliary tree. Then we can look for GB wall thickness. GB wall thickness. GB wall thickness, if it is more than 3 mm, it is said to be thick, seen in acute cholecystitis or malignancy. Pericholecystic collection. Pericholecystic fluid collection seen in case of acute cholecystitis. Okay. Then we can also look for the posterior acoustic shadowing seen in GB stones. Liver, you can also assess with the help of ultrasound whole abdomen. So these are some of the important things that we see in case of ultrasound. Coming to blood investigation. For blood investigation, in a patient of gallstone disease, most common investigations are total leukocyte count, liver function test, PT-INR for operative intervention. All the basic investigations, blood investigation also we do. Then MRCP. MRCP is a diagnostic investigation, and ERCP is a diagnostic plus therapeutic procedure. So what is MRCP? So magnetic resonance cholangiopancreatography is a non-invasive modality that provides excellent images of gallbladder as well as the biliary system. So MRCP provides image for both the GB and the biliary system. That is endoscopic retrograde cholangiopancreatography is a technique used only as a nowadays only as a therapeutic modality in patients with obstructive jaundice, because diagnosis mainly done by ultrasound and MRCP. So ERCP we nowadays used only for therapeutic purposes. Here what happens, there is a side viewing in ERCP. In ERCP there is a side viewing endoscope through which we go and cannulate the ampulla of Vetter. Ampulla of Vetter we cannulate and injected dye to see the biliary tree. So do therapeutic intervention by ERCP such as stone removal or stent placement to relieve obstruction in case of CBD stones or any kind of strictures. Last one is plain X-ray abdomen. Plain X-ray abdomen, basically we don't do plain X-ray abdomen to diagnose gallstone disease because only 10% of gallstone are radio opaque. So we do other investigations of complications like gallstone ileus, where there is a perforation, then definitely this is helpful. So here I have shown the ultrasound image of a gallstone. See this hypoechoic structure is the gallbladder. See, this is the gallbladder, and here this hyperechoic white structure, these are the calculi, these are the gallstones. This part is liver, okay, this is GB, and these are the stones. How do you know that these are gallstone? We can see the shape of this hyperintense structure, also posterior acoustic shadow. Can you see the black part? This is the posterior acoustic shadow. As it is, second picture also same. Second picture also same. This hypointense organ, this is the gallstone. These irregular structures, these are the calculi, and posteriorly you see a black area, a shadow, that is the posterior shadowing because of the stone. And in the second picture, in diagram number 2, you can also see around the gallbladder there is some fluid collection. So that is pericholecystic fluid. It means GB wall is also thickened. It means it is a case of acute cholecystitis, not a case of simple cholelithiasis, but it is a case of acute inflammation of the GB. That is why we are getting pericholecystic fluid and thickened GB wall. Now let's see. Let's move on to the next picture. Image of MRCP of normal GB. See, normally GB will look like this. This is the clear hyperintense structure, that is the gallbladder. Here we can see right hepatic duct and left hepatic duct together. They form the common hepatic duct, then cystic duct, they form the common bile duct. This is the common bile duct up to here. And what is this? This is the pancreatic duct. Can you see? This is the pancreatic duct, and this one is ampulla of Vetter. So this is duodenum, and the dye loop of the duodenum, and in MRCP the bile itself acts as a contrast media. So bile is coming to the duodenum. There is no obstruction. Second picture. Now we compare compare this first one with the picture below. Same MRCP image. Only thing is here you are seeing a black structure. This is the GB stone. In the cystic duct also, here you have seen these stones are there. Shadow, black shadow. These are the stones. These are the stones in the gallbladder as well as the CBD. Third picture is same. Gallbladder full of multiple calculi causing filling defect. So multiple gallstone on MRCP. So this is what MRCP looks like. Same. So coming to the next slide, it is okay. Coming to the next slide, it is ERCP. So this is what we are talking about, ERCP. The structure you are seeing here, this is an endoscope. This is an endoscope. Side viewing gastroduodenoscope. Okay. Through this endoscope, if you see, there is a needle. Through this endoscope, we reach the ampulla and we cannulate. We cannulate the ampulla better with a dye. Once we inject the dye, we can see the entire biliary tree. We can see the pancreatic duct clearly. Here, this is the GB full of stone. This is the gallbladder. These are the stones. This is cystic duct. Stones are present. This is the right and left hepatic duct, common hepatic duct. This is CBD. And the right side, it is the pancreatic duct. And this is the endoscope. Okay. So coming to the next picture, this is the therapeutic intervention done by ERCP. What we are seeing here, see, in this second middle diagram, this one, you can see there is a Dormia basket. This is the Dormia basket that is introduced through the common bile duct. So what is Dormia basket? It is a specialized wire catheter. So this Dormia basket is a specialized wire catheter. Dormia basket is a specialized wire catheter used to capture and remove the gallstone or the pancreatic stones. Okay, how it is done? We have inserted the endoscope with the help of this ERCP. With the help of this ERCP endoscope, we can do a sphincterotomy to widen the papilla opening. And then the Dormia basket is inserted. Okay, Dormia basket is inserted into the duct via the working channel of this endoscope, and often it is tracked with the help of a guide wire. Okay, so we have introduced it. Then once this Dormia basket passed the stone, okay, once past the stone, then the assistant opens the basket by pushing the catheter's handle, and we pull the thing together so that the stone is also pushed towards the sphincter and extracted. The basket is gently closed and retracted. Thus, the stone is also extracted along with the basket. Lithotripsy, mechanical lithotripsy can also be done with the help of this procedure. Now, what may be the differential diagnosis for a case of gallstone disease? First and the most common one is appendicitis. Gallstone diseases sometimes may mimic appendicitis. Perforated peptic ulcer, then acute pancreatitis, acute pyelonephritis, myocardial infarction, pneumonia of the right lower lobe. These are the most common differential diagnoses for gallstone diseases. So there are several important topics in the chapter of gallbladder. One is asymptomatic gallstone. One is acute cholecystitis, which we will discuss in next part. Chronic cholecystitis, ascending cholangitis, obstructive jaundice, very important for both practical and theoretical purpose, and gallbladder cancer. All of these topics I'll discuss in upcoming videos. Two will be about the treatment of gallstones and details on acute cholecystitis, all the classification and guidelines for acute cholecystitis. Till then, stay tuned, like and share for more such videos. Please subscribe to my channel. Thank you.